Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher if you've been out in practice for a while. Perfect for those going through pharmacology courses. Simply an email is going to get you access to that. Absolutely no cost other than that. We just signed up for when we have new podcast episodes available and other new content. So a couple examples on that. We've recently released a pharmacology flashcard book. Also recently released a pharmacology crossword puzzle book as well. So those can both be found on Amazon, Flippin' Pharmacology flashcards, and the MedEd 101 pharmacology crossword puzzle book. All right, let's get into the drug of the day today, and that is Lovastatin. Brand name of this medication is Mevacor, and this statin is not used very often. I see it occasionally, usually in patients who've been on it for a really, really long time. But I definitely wanted to go over some clinical pearls with this medication because there are some important reasons why we generally prefer rosuvastatin or atorvastatin, which are probably the most commonly used statins. So first and foremost, it being a statin, it inhibits HMG-CoA reductase. So if you remember, that's an enzyme that plays a critical role in basically the formation of cholesterol within the body. So by blocking that enzyme, you ultimately reduce the amount of cholesterol in the body, and primarily what we're looking at reducing is LDL. Dosing of this medication is usually 20 to 80 milligrams. Remember, we have low, moderate, and high-intensity statins. Lovastatin does not meet that 50% threshold. It is not considered a high-intensity statin. So that's kind of one strike against Lovastatin compared to some of the other higher-intensity statins like rosuvastatin and atorvastatin. Of the other statins, it does get a fairly high reduction with the highest dose. It's 40 up to like 48%, high 40s, as far as that LDL reduction, which is more than some of the other statins other than the two I mentioned before. Indication for this medication, obviously we're going to lower that cholesterol. That's the primary indication. Also ASCVD risk reduction through reducing LDL. So spelling out those dosages a little bit more, at least reiterating that point, 20 milligrams, or I should say maybe under 40 milligrams, is going to be considered low intensity, and 40 to 80 milligrams is going to be in that moderate intensity reduction of LDL stage. All right, let's get into drug adverse effects. So first and foremost, the things that I see in practice and what patients are going to ask about is muscle pain. It isn't crazy common when you compare it to the rates of placebo in clinical trials and things of that nature. But there has historically been maybe an over-reporting where you basically educate patients about the side effect. And maybe they over-report that or exaggerate that effect, or maybe there's some mental component there. So there's definitely some evidence out there that may indicate that patients maybe report it a little bit more, whether that be a placebo-type feeling. But it definitely does happen periodically. Ultimately, if that myopathy, muscle pain, is severe enough, there are rare instances where it can cause rhabdomyolysis and ultimately cause renal failure. So that is a risk. Again, not incredibly common with how frequently these statin drugs are used, like Lovastatin, but it does need to you need to pay attention to it for sure. Rare reports of hepatic impairment, cognitive impairment, that might be something you hear patients ask about. There's conflicting evidence that, maybe it can cause some mild impairment, and then other evidence has shown maybe not quite so much. Some of the evidence maybe says, trending more towards lipophilic agents, and lovastatin is a lipophilic statin. Maybe there's a slightly higher risk. By and large, it's a very, very small percentage, at least in my opinion, when it comes to that. If I had a patient come to me and saying, hey, they just started lovastatin, and, they notice their husband, wife, loved one, whoever, they notice a little bit of memory loss, memory issues, that's probably a situation where I would maybe look at switching statins. So if they were on lovastatin, maybe switching them to a hydrophilic statin, maybe holding the dose for a short period of time, maybe reducing the dose. So there's different options to pursue there if it is felt that, we're causing some cognitive issues with the medication. So it's not just a total all or nothing thing, like, nope, they should never be on anything like this again. Obviously, unless it's a really, really severe case or something wacky, but certainly think about the options and what options we have, such as reducing the dose, changing the medication, and things of that nature. One other kind of controversial thing that I wanted to address as well was the slight risk for diabetes development. Typically, in that association, this is another one where we've had maybe some conflicting data as to, some studies saying, yes, it is a possibility, and others saying not. So in the ones that maybe did, it's probably higher dosages and or using, greater potency statins type of thing. But if you think about it, using, higher dosages and higher potency statins, these are probably going to be patients who've had a heart attack and that type of thing. And, reducing the risk of that heart attack is probably going to outweigh any risk, any very, very small risk of developing diabetes from these medications. But again, the jury's still kind of out, and our data on this isn't great. It's a lot of observational data, I believe. So with that said, it's not something that I consider too highly, but it definitely is something good that you'll probably have to address with patients, because you certainly will see that reported online and things of that nature. All right. Other adverse effects, there's a laundry list listed in the package insert, rash, headache, things of that nature. I'm not going to go through all that. Again, not incredibly common, but, use your common sense there. If it's medication started and we're seeing, new signs and symptoms of something, obviously, we've got to make sure we rule out the medication. One interesting thing that came along in 2021 was the FDA actually removed the contraindication in pregnancy from the statin class in general. So I would say in pregnancy, we're generally going to avoid statins. It is not contraindicated, so in rare cases, if there was a risk-benefit analysis done and a patient was at incredibly high risk for cholesterol issues, then there could be a risk-benefit discussion there about whether to use statins in a certain pregnant patient or not. By and large, it's going to be avoided in pregnancy there. Pharmacokinetics. It is a lipophilic statin. So what this usually means in practice is if you utilize a lipophilic statin first, let's say, for lowering cholesterol, and patient doesn't tolerate it for whatever reason, the most common thing is to switch to a hydrophilic statin. So usually the most commonly used are, atorvastatin is a lipophilic statin, and then rosuvastatin is a high-intensity hydrophilic statin. And again, lovastatin is a lipophilic in that classification with atorvastatin. Other things from a kinetic standpoint, lovastatin has a very short half-life. I actually struggled to find the exact half-life on this. I saw varying reports from 1.1 to 3 hours as far as the half-life of lovastatin. In general, the practicality of this, what this means in practice, is if you've got a shorter half-life statin, it's generally better to dose that. It's going to be more effective to dose that medication at night. So that's what you're going to see with lovastatin and that type of thing. CYP3A4, I'll talk about that with drug interactions, but it is broken down by CYP3A4. And interestingly, absorption is altered by food, and absorption actually goes up when we give lovastatin with food. So that is generally recommended there. And then quickly, monitoring parameters. Obviously, LDL, lipid panel, we're going to follow that. So LFTs and CPK are not routinely recommended. Both are kind of going to be as clinically indicated. So LFTs, if you have a patient with signs and symptoms of liver toxicity, that's a situation where obviously we're going to look at that and then potentially look at the statin as a contributing factor. Again, extremely rare that statins cause hepatic issues, but there have been certainly case reports. And then CPK, same thing. It's a good exam question frequently. I've seen throughout my career in pharmacology classes as well as final exams, board exams. So CPK is the marker that we may look at if we see that muscle pain, and that may be indicative of rhabdomyolysis. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study materials like BCPS, ambulatory care, BCMTMS, geriatrics, or the NAPLEX exam, go check out meded101.com/store, S-T-O-R-E. We've got a great list of resources there. If you're looking for a gift for a pharmacy student, medical student, nursing student, release of 2 new things on Amazon, Flippin' Pharmacology flashcards, and the MedEd 101 Pharmacology crossword puzzle book. 2 great resources, both are on Amazon there, that can definitely help prepare pharmacology students for passing exams as well as board exams when they're trying to become a licensed healthcare professional. So go check out those resources and support the sponsor. All right, wrapping up with drug interactions, we've got CYP3A4 interactions. So any type of CYP3A4 inhibitor, clarithromycin, erythromycin, azole antifungals, protease inhibitors used in HIV, these can all increase concentrations of lovastatin, make it more and more likely that we run into myopathy, rhabdomyolysis risk, and things of that nature. So CYP3A4 inhibitors increase concentrations. CYP3A4 inducers, rifampin, St. John's wort, they can certainly lower concentrations of lovastatin. And then on the kind of direct insult, increase myopathy risk, niacin, fibrates, those are all older agents that have been used for cholesterol management. They can potentially have an additive effect and further increase the risk for myopathy, muscle pain, and potentially rhabdomyolysis as well. So those are the big interactions with lovastatin, and I think that's going to wrap up the episode for today. Thank you so much for listening. I hope you enjoyed this podcast episode. Please leave a rating and review on Amazon or wherever you're listening. I greatly appreciate that. Also, if you want to reach out to me, you can do that at mededucation101@gmail.com, or you can track me down, Eric Christensen, PharmD, BCPS, BCGP on LinkedIn. If you want to support the sponsor, I greatly appreciate that. You can find all those links in the show notes as well as on meded101.com/store, S-T-O-R-E. Thanks so much for listening, and I hope you have a great rest of your day.